So next we invite Dr. Shushmita. Do we have Dr. Gopalakrishnan here? Yeah, so you will be the next presenter.
Good morning, everyone. Today I'm presenting my topic is the practical use of white blood cell as inflammatory markers in the prediction of corneal pathology. There is no conflict of interest and no financial support. Introduction: eye disorders are characterized by some degree of inflammatory burden. Corneal pathology encompasses a wide range of infections, inflammatory conditions, degenerative diseases that can compromise the vision and ocular health. Studies have often focused on specific white WBC cell markers such as the NLR due to their established significance as indicators of inflammation and immune response. However, it's essential to acknowledge that WBC population is diverse and consists of various subtypes like neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Each of these subtypes play a unique role in the immune response and can provide valuable information about the different aspects of inflammation and the disease progression. This study aims to understand what an elevated ratio might mean for a patient with eye disease and to help clinicians institute early interventions and hence to improve the outcome. My aim is to determine the ratio of neutrophil to lymphocyte, lymphocyte to platelet, and monocyte to lymphocyte ratios in corneal pathology and to assess the best parameter among the three as a better prediction in corneal pathology. The study design is a case control study. Duration is 1 year. Sample size consists of 60 cases and 60 controls. My inclusion criteria were patients with corneal pathologies, and while those with healthy corneas was considered as controls. Exclusion criteria: those who underwent ocular and adnexal surgery in recent 6 months with a history of corneal contact lens wear within 6 months, those who suffered from active ocular inflammation, corneal ulcer, glaucoma, diabetic retinopathy, thyroid associated ophthalmopathy, AMD, those who suffered from fever, URTI, LRTI, UTI, recent trauma, acute chronic infection, and also with a prescription history of topical or systemic immunosuppressant and hormone medication in the past 3 months. Method of collection of data: all patients attending ophthalmology OPD in Jalapa Hospital, Kolar, fulfilling the criteria and after taking their consent was considered included in the study. Evaluation of the patient with a detailed history regarding their complaints was taken, including the socio-demographic profile, systemic disorders, long-term drug therapy, ocular trauma, and surgical history. An extensive ophthalmic assessment was conducted, such as visual acuity assessment, slit lamp biomicroscopy, pachymetry, specular microscopy, anterior segment OCT, and fundoscopy. Peripheral venous blood samples was collected from all the participants. A CBC was performed by automated flow cytometric method, and the counts of WBCs were recorded. The NLR, PLR, MLR was calculated by dividing the ratios to the lymphocyte counts. My results: the mean age of the patients were plus or minus 50 years. There was no statistically significant difference between the cases and controls with respect to age and gender. Distribution of subjects according to the occupation: most of them were had outdoor occupation. Among the cases, 62% had corneal opacities, 12% had keratoconus, 12% had corneal degenerations, 10% had healed corneal ulcer, and 5% with corneal dystrophy. Comparison of mean neutrophil lymphocyte ratio among the cases and control shows there was no significant difference. There was statistically significant difference found between the cases and the control with respect to the neutrophil lymphocyte ratio. Coming to the monocyte lymphocyte ratio, there was statistically significant difference between the cases and control with respect to the ratio, as well as there was statistically significant difference found between the cases and controls with respect to the platelet lymphocyte counts. NLR was found to be better predictor among the three parameters, followed by monocyte lymphocyte ratio and platelet lymphocyte ratio being the least among the three. Discussion: in the present study, NLR, MLR, PLR inflammatory markers were significantly higher in patients with corneal pathologies compared to healthy controls. We demonstrated for the first time that in addition to NLR, other WBC markers were also significantly higher in corneal pathologies. Our research meticulously included cases and controls with total counts within the normal range, meticulously excluding active ocular inflammation. Despite this, all the three demonstrated elevation. Notably, our study marks the first to compare WBC markers across various corneal pathologies. Furthermore, NLR emerged as the paramount parameter in demonstrating inflammatory status among the three. Recent study shows that monocyte plays a key role during the inflammation process. Activated monocyte induces the expression of many pro-inflammatory cytokine and adhesion molecules. Similar studies done by Emin et al. As well as Otlu demonstrated the fact that NLR is associated with the severity and poor prognosis of the disease, which were correlating with our own study. By concluding, the study reveal a significant elevation in inflammatory biomarker levels despite normal WBC counts and absence of active inflammation. This suggests a potential ongoing inflammation or inadequate treatment efficacy. The complexity highlighted requires an investigation to elucidate the underlying mechanism and optimize therapeutic approaches in managing corneal